Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist in Seattle, Washington, and the founder and CEO of GRACE, the global resource for advancing cancer education. We'll continue with the second part of our webinar program with Dr. Mark Millard, Medical Director of the Baylor Martha Foster Lung Care Center and Professor of Pulmonology at Baylor University Medical Center in Dallas, Texas. This program, following Part 1 on the history of tobacco and its association with lung cancer, will now cover smoking cessation strategies. Our podcast is co-sponsored with our partner, the Longevity Foundation. Following Dr. Millard's presentation, we'll have a question and answer session on this topic.
Now, how do we stop this epidemic of smoking? And I think it was epidemiology that sort of put the relationship between tobacco smoke and lung cancer on the map. And I think if you look at the current modern epidemiology and the way they approach epidemics, it's useful in terms of instruction about where we are and how do we need to go about stopping this epidemic of tobacco use and encouraging tobacco cessation. And so in the epidemiology model classic that's published in Epidemiology Journal of Preventive Medicine by Giovino, he applies the epidemiology to the model of tobacco use. And you always have the agent, what's the causative thing, and that's cigarettes. And the host is the person who smokes, and the vector is, well, how do we get the agent into the host? And the answer is because of a market strategy. And then finally, you have the environment that encourages tobacco smoking, and you have the consequences of tobacco smoking use, addiction, disease, and death. So you have this model, and when you look at this four-quadrant model, you can begin to develop strategies that may be able to deal with each aspect. You can understand how the agent has sort of been manipulated and continues to sort of mutate, so to speak, to try to gain more entry. And actually, I read the other day that a couple of decades ago, one of the tobacco companies introduced into the market this strain of tobacco that actually had double the dose, double the amount of nicotine per gram of tobacco. And that really jacked up the content of nicotine in each cigarette, and the FDA actually used that as justification for then beginning to monitor nicotine levels because they said this is deliberate manipulation of the marketplace. And the cigarette companies were just trying to sell more nicotine and trying to get more people addicted. You can look at the vector market strategy, and certainly these are areas that we can prevent transmission by reducing the appeal, by focusing, by getting the marketing removed. You know, there are no more cigarette ads in the airwaves. There are no more cigarette ads on TV and radio. And you can also see how the tobacco companies are trying to get around these with direct mailing and retail, the environment, and the host finally. Lots of things. But this is a very instructive model to help us look at the problem and then try to come up with strategies to stop smoking. The U.S. Public Health Service has published this straightforward algorithm for every time the patient is seen in the office. And the fact is, when I go to my internist, I should be asked every time, do I smoke? Or have I been smoking? Or how much are you smoking these days? That's critical that every encounter with a healthcare professional, the question about tobacco use should be added. And if the patient is smoking, then you have to say, do you want to quit? And that's very important because if somebody wants to quit, then there are 5 A's. If somebody doesn't want to quit, and you assess it real quickly, there's no reason beating on them to say, stop smoking. You're stupid. I mean, you need to find what motivation, what sort of receptors are there out there that you can tweak that maybe can bring a person around to that sense of, wow, you know, maybe I do need to stop. And it's always important if the patient did previously smoke to encourage continued abstinence and prevent relapse. Now, the 5 A's and 5 R's, what are they? The 5 A's are, for people willing to quit, it's always important to ask about tobacco use, advise the patient to quit, assess willingness to make a quit attempt, assist in the quit attempt, and finally arrange follow-up. And if somebody doesn't want to smoke, and say you've got a friend or a loved one or somebody who doesn't want to smoke or a patient, it's very important that we still talk about that. And one of the things you don't do is say, you're so stupid, I can't believe you smoked. And one of the things is to encourage patients to think of the relevance of quitting smoking. Why is it important? How much money would I save? I mean, would my health insurance get less? And you know, my healthcare system, Baylor Healthcare System, recently introduced a policy where they will not hire tobacco users. If you get a urine test for nicotine and it's in your bloodstream, it's in your urine, you're not going to be hired. And old hires, current employees aren't going to be fired if they use it. But if you are a tobacco user, then you have to pay a higher healthcare premium, about $600 a year more. So, again, there's an economic issue. We assist patients in identifying the risks of smoking in terms of what are the issues, what are the health-related problems, and what rewards are there of smoking cessation. And it's important to discuss roadblocks or barriers to attempted cessation. And again, every time a healthcare professional sees a patient, again, motivational intervention is very, very important. The American College of Physicians in 2007 came up with this sort of paradigm of smoking cessations. What kind of interventions do we have? Do we do telephone? Do we do individual therapy? Do we do group therapy? Do we do self-help? And they identified resources that can be used and in the community for the purposes of smoking cessation. And again, to reiterate, it's not just lung cancer. It's just like smoking touches so many organ systems. The diseases of tobacco related in terms of increased cardiovascular disease, heart attacks, stroke, cancer, COPD, emphysema, worsening asthma, all of these things, there's a global reason to stop smoking. I mean, you can almost talk an organ system, and I can tell you a complication that tobacco smoke can bring on it. So how do we get somebody to stop smoking? More practically, we do the 5 A's, and we assess, and yeah, they want to stop smoking. Okay, so what do we do? And this is from a recently published article in one of the journals. You ask the patient, do you want to stop smoking? And if they do, you talk about, do you want to just try to stop on your own, or do you want to try medication? And you have 3 general sort of bins of different general medicine strategies. One is stuff that's over-the-counter, nicotine replacement therapy. This can be effective. Nicotine replacement patch, gum, inhaler, lozenge, nasal spray. Recently, the e-cigarette, which is often made in China, believe it or not, and there's some quality control issues about what's in it, but certainly it does deliver nicotine. People feel like they're getting nicotine replacement. Is that the way they want to try it? And I often personally will encourage somebody first, if they have never used it before, to go with nicotine replacement therapy, because the addictive substance in tobacco is nicotine, no question. I mean, there's a certain amount of behavioral stuff involved with it, you know, the cup of coffee and the cigarette in the morning, but usually it's because you need that nicotine, that's that feel-good. And nicotine binds to receptors in the brain and certain part of the brain that are associated with pleasure. And what nicotine does when you smoke a cigarette, it's kind of like when you solve a problem or something good happens and you say, yes. Well, that's the same receptor that makes you say, yes, great, touchdown catch or whatever. That is a nicotine receptor that's being fired off. Now, it's not with nicotine, it's with another substance, but it hits that same kind of neurotransmitter, that same kind of feeling, and same kind of sensation that you get with a puff of tobacco. And one of the things that the brain learned about real quickly was nicotine sticks around longer than those briefly released neurotransmitters that happen when something good happens, when you solve a problem, when something great happens, when you win the lottery or whatever. And so the brain after a while says, you know, if I have more of this tobacco stuff, this nicotine, it lasts longer. And so that's one of the reasons why nicotine is, I mean, that's the stuff of addiction. And so providing that without the behavior of smoking or without the tar and all the other volatiles there certainly can cut down on a lot of diseases. Nicotine per se doesn't cause cancer. Nicotine per se doesn't cause emphysema. It does have vasoactive and neurotransmitter issues, but it doesn't cause lung cancer, and nicotine doesn't cause COPD. So that's one option. Or we have bupropion. The trade name is Zyban or Wellbutrin, and bupropion was initially developed as an antidepressant, and it was observed by the investigators that, you know, a lot of the patients who are taking this medicine also stopped smoking at the same time. And so they looked at that and they said, wow, this is sort of an unintentional side effect, is that they stopped smoking, and nobody was sure why. But bupropion was one of the first medical treatments of smoking, and it's clearly more effective than nicotine replacement or behavior counseling alone. The primary sort of contraindication is people who've had previous seizures. There are other medicines that have had the same sort of sideline benefit that becomes almost the primary reason for using it. Psychiatry still uses a little bit of bupropion, but it's used more for smoking cessation than anything else. I think that the medicine that's the most famous medicine that it's a side effect of which became the primary reason for use it actually was a medicine called sildenafil, and sildenafil was a medicine that was being developed for hypertension and nitric oxide inhibitor, and so they tried it. in this group of people to see if it worked on hypertension. It was okay. It wasn't as good as others. But when they tried to get the medicine turned in, they couldn't get any of the men to turn back into sildenafil. The placebos always got in, but the real one weren't there. I said, well, why in the world? So they finally were able to figure out, oh, there's something about this stuff. And the fact is, what's sildenafil? Well, sildenafil is Viagra. And it's a bad antihypertensive, but sure is good for erectile dysfunction. And so bupropion, it's okay as an antidepressant, still used, but its side effect is that it's a nonspecific blocker of nicotine in the brain. And so it's useful. It's been shown. It helps people stop smoking. They're not addicted. They don't have the withdrawal from nicotine. And now, most recently, you have this designer drug, Varenicline, called Chantix. Chantix is sort of specifically engineered to hit that nicotine receptor in the brain, bind to it. You get a little bit of the feel-good from the nicotine, but not too much. The other pernicious thing about Varenicline, in a good way, if you could use that term in a good way, is that it may block feel-good feelings when you smoke a cigarette. In other words, you smoke a cigarette in the morning, you wake up, oh, I got to have a cup of coffee, and my cigarette, and you have the cup of coffee, and that's good. You light up the cigarette, you take a puff, and nothing happens. And that's because the Chantix has blocked the effect of the nicotine. Now, there is an FDA caution. I think there's some slides on the road that will talk about this, but the fact is that Varenicline is probably the most effective pharmacotherapy right now to get people to stop smoking. And you can choose monotherapy. It doesn't work as well, obviously. Some people will have more recently added nicotine replacement to Varenicline or to bupropion. There are lots of ways to do it. The key thing is there are specific things that we can do to get our patients to stop smoking. Now, Chantix costs about $100 a month, give or take a little bit. The world can't afford that. We have trouble with funding Medicare, much less funding all these smoking things, and the world has much less money than we do. And there is the need for a low-cost nicotine antagonist. As it turns out, cytosine is fairly effective. And when you look at just cytosine versus placebo in terms of abstinence for 12 months, you find that there's almost a 3- or 4-fold increase in the ability of people to stop smoking. And this is cheap. Apparently, it's like water almost. So it's very inexpensive, and we'll hope that this at some point will be introduced into the marketplace, which will really make it a lot cheaper to get people to stop smoking. Now, I want to move briefly into clinic. This is the American College of Physicians proprietary smoking cessation clinic, and it's a great summary that's worth looking at. We should consider the type of smoker who should be considered for smoking cessation, people who can't quit after behavioral interventions, heavy smokers. If somebody asks for it in terms of, doc, I need to stop, I can't stop on my own, that's important. And also smokers who are at high risk for adverse health effects, certainly patients with established lung disease, heart disease, and somebody who is thinking of getting pregnant. Very important, because none of these studies, either Varenicline nor bupropion, have been studied in pregnant women. That's the population you stay away from. You're not supposed to, so nobody knows what happens in pregnancy, and the safety is unknown. In terms of seizures, eating disorders, you really don't want to use bupropion. Renal disease, since Varenicline is cleared by the kidneys, you might want to hold that, and bupropion can have some problem with hypertension, of course, cardiovascular disease. If you use nicotine replacement, that can increase blood pressure. Now, nicotine replacement clearly relieves withdrawal symptoms. There's always the thing about people, couples would come into my office, and I'd say, well, are you interested in stopping smoking? And the wife looks at me and says, no, he's not, because I can't take it anymore. I can't take it. He's a bear. Or the guy says, this lady, she becomes a witch when she stops smoking. I mean, clearly, smoking cessation attempts, there's a lot of emotion associated with it. So nicotine replacement sort of helps that, and all forms clearly help in motivated patients. All the forms of nicotine replacement increase the quit rate. And the typical dosing, I think you're at your leisure in terms of the way you give it. You give the gum, the patch, the spray, the inhaler, the lozenge, the e-cigarette. It's not approved, but it's all these things you dose for satisfaction, and then you back off over time. And you really try to back off. Now, bupropion was the first medication approved for smoking cessation that was non-nicotine, and it clearly worked when compared with nicotine replacement. There's an article in the New England Journal of Medicine that showed that bupropion did help, but there are not a whole lot of articles out there. There are studies that clearly show that there's an improvement in the quit rate about twice that seen with nicotine replacement. So there's no question that Wellbutrin or Zyban or the Bupropion needs to be the sustained release. The Bupropion sustained release or the extra length or whatever it is, you take 150 milligrams twice a day, and that's the sustained release formula, and that works. And you use it as long as you need it, frankly. If you need it forever, take it forever, because let me tell you, going back to smoking is fine, but obviously at some point you try to back off, you try to stop it and see whether or not the patient can then sustain quitting. In terms of the Varenicline, I think that's the next slide up, is designed specifically for smoking cessation. It binds to the nicotine receptor and has an improvement in the quit rate. Now, the issue with Varenicline is you can smoke and take it. Since one of the major side effects is nausea and vivid dreams, you start on a low dose, first once a day and then twice a day, and then you double the dose. And it says for 12 weeks, and the fact is you can take it for a long time. There's some additional studies since this was released that suggest that you may need to take it for longer to keep down the recidivist rate. And obviously, if you have somebody with kidney failure, you've got to dose adjust, and there's no studies in pregnant women. I should say one more thing about Chantix. There's been a lot in the media about suicide and depressive events. Recently, the FDA, I think it was in October of this year, released a statement. They had looked at 2 studies that were done looking at nicotine replacement versus Chantix in smokers, and they found that there was no increase in psychiatric hospitalizations or serious psychiatric events when you compared Chantix to nicotine. So clearly, you have to educate your patients to say, if you start feeling crazy or you start having problems or you start saying stupid things, you feel bad or different or funny, and we're not talking about, funny ha-ha, stop the drug and call me. I mean, very clearly, you don't give it PRN refills. You have to monitor it, and it's very important. So other therapies, clonidine, alprazolam, I've never used silver acetate, don't know even how I'd get it. But, this is part of the ACP module, and there are some other nicotine antagonists, which means that you don't get any effect at all, if not some bad effects. And is there a problem with quitting? And the answer is weight gain is one of them. Clearly, people weigh more, and women gain on average 5 kilograms, which is 12 plus pounds more. And the issue is, do I want to die fat and happy, or do I want to die thin and miserably? I think that the weight gain, really, when you consider it, is not the issue as much as it is the diseases that are prevented, delayed, when you stop smoking. Nicotine gum and bupropion may be shown to delay but not prevent the weight gain. I've not used any naltrexone, so I can't speak to the anti-opiate use of it in terms of patient concern about gaining weight. I just know that any way we can get our patients to stop smoking that doesn't put them or us in jail is worth it. So let's see, depression, people who stop smoking may develop depressive symptom. Again, we all know about this smoking rage when they stop smoking, and this is a real issue. Perhaps bupropion might be a good choice for those in whom depression happens worse, and that has to be looked at, and you have to monitor it. So the good news and bad news, the good news of stopping smoking is right away you reduce the risk of cardiovascular complications and neoplasia. It takes about 10 years for the risk of lung cancer and other malignancies to come down to its lowest level. It never becomes that of a non-smoker, but it becomes just a smidgen above. But after 10 years, you can sort of like breathe a little bit of sigh, say, I've made it down 10 years. Reduce exacerbations of asthma, progression of COPD, no question. We wouldn't see COPD were it not for tobacco. Cost savings is getting very expensive. And I think it's curious that there are some medicines that actually are influenced by tobacco in terms of the metabolism in the liver. Medicines like theophylline, we don't use that anymore, but we do use clozapine occasionally, which is a psychiatric drug, and some other medicines. So it's important that we need to recognize that there's no action without a reaction and look at the pharmacopoeia of medicines and ask, do we need to adjust doses if somebody really is successful at stopping smoking? In the COPD world, we used to use theophylline a lot. And in that situation, when people stopped smoking, we had to drop the dose off or else they'd become theophylline toxic. Fortunately, we don't need to use that much anymore. So I think this is my last slide, and it's the currently proposed new package labeling for tobacco. And the tobacco companies have sued, and it's going to go to the Supreme Court, and there's a lot of issues on this. Does this violate free speech by putting this kind of very graphic slide on the package of tobacco? And this is going to be something that is decided by the courts, but clearly there's no question we need to do everything we can to cure this epidemic of tobacco use in this country and in the world as well. And I think that's my last slide, and I appreciate the opportunity to present this information. I hope it's been helpful, and hopefully that this is an encouragement to everybody to keep working on stopping smoking today, tomorrow, and in the days to come.
Thank you very much. That was a remarkable presentation and very complete. I really appreciate it, and I know many of our viewers and listeners will as well. I wanted to cover a couple of questions, and one is about the concept of who should be doing smoking cessation counseling. And you made the very good point that every medical encounter is an opportune time to intervene. At the same time, there are a lot of agents here and a lot of approaches. It seems both time-consuming and complex. And so I would ask, in your experience, are most primary care physicians, most pulmonologists equipped with the skill and time to do this well? Or is this something that, in your mind, most institutions should have a person or a clinic dedicated to smoking cessation that the primary care front line or maybe any doctor and healthcare professional should be screening patients for their candidacy to pursue?
Well, that's a great question, and there are a number of colliding issues with that question. First of all, 20% of the country smokes, so there's no way we can have one employee per hospital or one employee per hospital system or two or three to deal with 20% of people. So I think there is a role for the dedicated tobacco cessation counselor. In the state of Texas, where I practice in and lived about 10 years ago, some money that filtered into our healthcare system for tobacco education, and for 2 years we had a great tobacco cessation program. The program ran out of money. No insurance company pays for tobacco cessation. I think the problem with putting it on the backs of the primary care doctor is the time. They may have the skill, and primary care docs are the Dr. Welbys of the world. They're the ones who's supposed to know everything about the person, because that's why they call it primary. We all know that what that really means is that their primary job is to refer to different subspecialists because they don't have time. And what's happening, in a sense, spending time with patients has become a casualty of changing reimbursements. And what we all have to do is try to figure out a way to carve out time and carve out that moment where we can say something to a patient, or we can say something to a family member, or wherever we are in the hierarchy of life. And the position is that we need to spend a little bit of time at least to assess the readiness or willingness to quit. Because if somebody is willing to quit, then you have a golden opportunity as a healthcare provider to give them the means to quit. If somebody isn't willing to quit, you don't need to waste your time. You just need to give them some information. We need to talk. Come back in 6 months. We'll talk some more about this. Consider this or that, and then move on. I think the primary care is the best way to do it because they understand the whole patient. They're the only one who has a list, hopefully, of all the medicines the patient is taking. We all should have it, but it's often only in the primary care chart. I think it's the primary care job. I think that's where the office are. Unfortunately, right now, they're not paid enough to do anything, much less extensive tobacco counseling.
Thanks. I wanted to bring up a topic that was actually the subject of a recent article in the Journal of Thoracic Oncology, and that was an analysis of costs and the potential benefit in terms of dollars per quality-adjusted life year of CT screening for lung cancer. And this is based on the National Lung Screening Trial that got a lot of publicity, justifiably, and was published in the New England Journal. But despite that trial that showed a very significant, both statistically and clinically significant survival benefit for CT screening, that hasn't yet become widespread practice. And part of the question is the financial feasibility of implementing a broad CT screening program for people in the age range of 55 to 74 who were in that trial and who have a smoking history. The article did a lot of data-based modeling and calculated that the impact of smoking cessation at the time of CT screening would really be associated with a remarkable impact on the cost effectiveness. if patients were counseled at a teachable moment to quit smoking, even if they were found to have dodged a bullet and not have a cancer, if that led to an increase in the rate of smoking cessation, that smoking cessation itself was a remarkably cost-efficient way to improve survival. But on the other hand, if patients might have felt exonerated to continue to smoke after a negative scan, and it leads to a decrease in smoking cessation rates, that it became remarkably expensive to see a survival benefit with screening. So I'm sorry for the long-winded question, but really I wanted to ask your impression of how smoking cessation might be integrated into CT screening for lung cancer, and if you have any experience of whether this leads to accelerated rates of smoking cessation or to people feeling justified to continue to smoke if they've managed to come out with a negative scan.
I think the tapestry is really very thickly woven. There are a lot of different threads in that question. For one, I think the point needs to be made that lung cancer screening was for people who were smokers and who are at risk for smoking. So if you never smoked, or if you stopped smoking probably 10 years ago, which is I think most of us feel the risk factor goes back to very little, you don't need screening. It would be a novel approach to be able to tie reimbursement for screening CT with completion of a tobacco cessation course for patients who are active smokers. And I think the problem is if you're not an active smoker, then you don't need to do that, so then are we discriminating against active smokers? But I think that would be very clearly the fear factor of getting people, oh, I think I have lung cancer, I'm going to stop smoking because, oh, wow, I just dodged a bullet by having a negative CT scan. That very quickly is overcome by the next need for the nicotine fix. The fear factor has been operative. I mean, we all know patients who the last cigarette they smoked was when they saw the spot on their lung on a chest x-ray and they, maybe I have lung cancer. But that's the exception more than the rule in my clinical opinion. And I think that, but tying smoking cessation to CT scans, I think you can model it. Of course, you can prove anything you want to with models, depending on the weight on the variables. But that certainly would be a requirement to me, is that if you want to get this thing paid for by insurance, you got to go through smoking cessation if you're an active smoker.
Thanks to Dr. Millard for his excellent presentation and to the Longevity Foundation, who worked in partnership with Grace to make this program possible. We hope it's helpful.